Good morning and good evening to everyone present here. I am Ramya T. Karu, Project Associate at IndoUSrare, and I extend a warm welcome to each one of you to the webinar, Genetic Counseling for Rare Diseases and Global Perspective. Before we commence with the webinar, let me provide you with a brief introduction of our organization, which includes, IndoUSrare mission and vision. IndoUSrare was founded with a vision to address the significant gaps in global diversity, equity, and access to clinical trials for rare diseases. Our mission at IndoUSrare includes uh, connecting all rare disease patients in India, US, and globally, collaborating for rare disease policy development and implementation between US, India, and other countries, organizing international conferences to bring together different stakeholders in the rare disease community, and facilitating cross-border research and advocating for rare disease patients. Under this mission, we currently have 6 patient-centric programs, which includes patient concierge, patient alliance, research programs, educational and awareness and advocacy programs, and corporate alliance. Our patient concierge program, which is a tech-enabled program, it connects and supports patients in need of clinical trials, experts, and partners, and provides resources for patient education. Currently, we have received 75 plus patient requests from all over the world, and we have, successfully catered their requests. So, and the next program which I would like to talk about is the Patient Alliance program, which where we have around 45 patient foundation advocacy groups who are with us across 3 continents. And it aims to, the Patient Alliance program aims to connect patient groups and foundation in the US with their counterparts, and also the patients in the Indian subcontinent and other low and middle income countries to accelerate research and care for rare diseases. We also have research programs, which include research core and various other research grant funded projects and education projects. And we also conduct education and awareness events comprising of webinar series, Rare Disease Day, Art for Rare, Road for Rare, and we have participated in various conferences and other engagements. We are also involved in the rare disease advocacy in the US and India, where we have participated in various advocacy events around the world. And other program that I want to talk about is the Corporate Alliance program, which aims to collaborate with pharmaceutical companies involved in rare disease research to ensure equitable and affordable access to therapies. Currently, we have 6 members in our Corporate Alliance program. Over the 4 years, we have actually partnered with 45 Patients Alliance members, 6 Corporate Alliance members, and catered 75 plus patients through our concierge, and also hosted around more than 25 global events. We are also proud to share that this year we have successfully hosted inaugural Indo-US Bridging Rare Summit, which was held in Washington, D.C. On October 29th and 30th. And next year, we plan to host the event at New Delhi, India, on November 16th to 18th. Now, I would like to introduce Dr. Nisha Venugopal, Associate Director of Research and Operations at IndoUSrare. Nisha has a PhD in Life Science from CSIR, that is Center for Cellular and Molecular Biology, CCMB, where she studied the role of primary cilium in adult skeletal muscle cells. Her postdoctoral research at the Institute for Bioinformatics and Applied Biotechnology, India, involved a detailed analysis of global clinical registries. At IndoUSrare, Nisha works directly with the leadership to coordinate with all her patient-centric programs that aims to improve the patient experience across different phases of the rare disease journey. With that, now I would like to call upon Nisha Venugopal to give us a brief overview of the webinar and to moderate this session.
Thanks, Ramya. Hello, everyone. Good evening and good morning to all of you joining us today. We have two very experienced genetic counselors from across the globe to speak with us today, and we hope for a very insightful session, and I'm very looking forward to it. Ramya, next slide, please.
Yeah.
Thank you. Yes, so we have Amy Gaviglio and Dipanjana Datta joining us, and they will be speaking individually before we move on to our panel session. Next slide, Ramya. A few housekeeping points so that we are all able to enjoy and learn from this meeting and insights being provided. Please keep your video off and microphone muted. You can type in any questions or queries you have in the chat box, and we will read them out to the panelists as time permits. And this meeting is being recorded and will be posted online on all IndoUSrare social media handles. Please do feel free to share your experiences and interact with other attendees using the chat function. We are all here to learn from each other's experiences. And if you have any queries, please do write to us at admin@indousrare.org. Our first speaker for today is Ms. Amy Gaviglio. She is a genetic counselor and consultant with a wealth of experience who has been working in the space for a number of years. She not only works in specifically genetic counseling, but also is an advocate and works for newborn screening. She's involved with a number of various rare disease organizations and is the chair of the NBS Expert Panel for Clinical and Laboratory Standards Institute, and is also the chair of Minnesota's Rare Disease Advisory Council. So she's very involved in advocacy for the needs of rare disease patients as well. Welcome, Amy. Over to you.
Thank you. Thank you so much. And I will see if I can share my slides. I think you have to stop sharing first. Perfect. Thank you. All right, so thank you. I want to start by first saying thank you so much to the IndoUSrare organizers for inviting me to speak today to be part of this important webinar. And my task for today is really to walk through what genetic counseling looks like in the United States, particularly around rare genetic diseases. So I often still, 15, 16 years later, find one of the hardest things to do as a genetic counselor is to talk to the public or individuals about what it is that we actually do. So I really like this graphic because it not only talks about what genetic counselors do, but also what we don't do. And so on the left side, you can see 5 key components of genetic counseling in the United States. So first and foremost, our role is really to spend time with families to help them understand genetic health information as well as genetic testing. And unlike a lot of other health professionals, especially in the United States, genetic counselors tend to have more time with patients, so we can take the time to really answer questions, explore concerns, explore fears around either the possibility of having a disease yourself, the possibility of someone in your family having a disease, and also providing information about testing options so we can better understand, what is happening in your family. A big part of genetic counseling, of course, is about providing information. And so this is information maybe about the disease or potential diseases that might run in your family, as well as various testing options, and talking about both the benefits and limitations and also the costs of genetic testing and a genetic based workup. But taken together, if we really kind of crunch down to what the role of genetic counselors, it's often to serve as care navigators. So helping to make sure families get connected to any other health professionals or specialists that they need to see, as well as to get disease-specific and other types of support services. So I do want to take some time and talk a little bit about on the right as well in terms of what we don't do, because I do think this is really important as well, and is often a bit confusing. So in the US, genetic counseling is what we often call non-directive, which means that we really try not to make any decisions for the patient, for the family about testing or reproductive decision making. It's really about empowering the family with information to make the decision that is best for them based on the information they have and the support that they have. Despite the fact that we do have the word counselor in our name, we are not typically licensed therapists or psychologists. So while we can begin to explore emotions and support and psychological considerations around genetics, we're really not able to fully address mental health issues that would require a separate health professional who is licensed in that area. We are also not prescribers, nor can we typically make kind of officially make the diagnosis. So ultimately, we are part of a team. So we are part of your healthcare team, and so we do not replace any other needed health professionals. So on the last side, I mentioned that one role of genetic counselors is to discuss and help families understand genetic health risks. And we do this by providing a number of services. So the first, again, is this providing information about genetics in general, about inheritance or how diseases are passed on in families, as well as really kind of honing in on specific genetic conditions or diseases. I mentioned this earlier as well. We'll discuss the benefits, risks, and limitations of genetic testing. I think often genetic testing is seen as this yes, no answer, and unfortunately that's not always the case. So we want to make sure that you are prepared for the wide range of information that might come back from genetic testing. Once testing results are back, we help interpret those results and help patients and families make decisions based on those results, combined with other important information like your medical history or your family history. And then, of course, understanding that this can be a life-changing experience for many families. We're here to provide support to patients, families, as well as other healthcare providers in the community, and making sure that anyone with one of these diseases reaches their best possible health outcomes. So while many people, I think, still think about genetic counselors working primarily in the prenatal space, there are actually quite a few specialty areas that genetic counselors are in now, including pediatrics, general genetics, adult genetics, and then very focused areas. So maybe cancer genetic counseling or neurogenetics, focusing on neurological diseases, metabolic disease, newborn screening, public health, as well as cardiology. So now that we have a better idea, hopefully, of what genetic counseling is, we'll walk a little bit through the anatomy of a genetic counseling session. And so here you can see that it is really set up to not only provide information to families, but also really this two-way communication, and making sure that at the bottom you can see kind of the ultimate goal is this family and patient goal setting and shared decision making. The genetic counseling session will, of course, talk a bit about the characteristics of the disease or diseases that we're looking at. We'll explore psychological aspects, how a family is feeling about this, what are their concerns, fears around disease, around genetic testing. We can also work with you and patients to help with talking with your family members. That can be very difficult and very scary, and so we can help support that. And talking again about how this disease may actually move throughout the family. We'll talk about possible results from any genetic testing and what those results mean and what next steps would be. and then making sure that families feel supported and have the information they need to make the best decisions for themselves. So I want to talk a little bit before I kind of start to wrap up for my section around cultural humility. I prefer this term over cultural competence because I think it's a bit more self-reflective and really important as we think about the global application of genetic counseling. And really, I think a vital component of genetic counseling is ensuring that it is being done with cultural humility. And so when I talk about cultural humility, I really am referring to this kind of orientation towards caring for someone's patients, your patients, that is based on being self-reflective, having self-assessments, and really appreciating the patient's experiences and expertise on their own social and cultural context of their lives. So really, thinking about all of these different ways that families, patients, you yourself are coming to a session and being open to understanding what is bringing someone there, what their concerns are, and kind of what their lived experience has been thus far. So I'm really trying to remain open and seeing the patient as an expert in their own lives, because they certainly are. So very quickly, I'll talk a little bit about where genetic counseling is in the United States right now in terms of numbers. So you can see we have quite a few genetic counselors really across the country. That's on the map on the right, as well as in Canada. So North America is quite well covered. And I know, one of the things that we talk a lot about in genetic counseling, especially now, is how can we make it more accessible? How can families reach genetic counselors more? Even though we do have a good number of genetic counselors, it's not really comparable to the population. And so we have to think of new ways to get genetic counseling to people. And so if you look at the graph on the left, you can see how much more we're doing things like telegenetics, whether that is a video call like we're doing now or a telephone only. Certainly these types of kind of electronic means of genetic counseling have really expanded our ability to reach more families and really reach them where they are, instead of having families have to travel to cities at quite some distance to get the benefit of genetic counseling. And we're also seeing a lot more genetic counselors that speak a variety of languages, which of course is very important for accessibility as well. And I think I'll end, this is my last slide, just to talk a little bit about the genetic counselor competencies that we focus on in the United States. And I like this because I think it really shows the gamut of what genetic counseling is all about in terms of how we practice and the things that we find to be very important in our role. So of course, we need genetics and genomics expertise. We want to be a good resource for families who have questions around genetic diseases. We need to understand risk assessment. So taking into account your family history, your medical history, genetic testing results, other lab testing results, and really get a sense of what the risks are. We've talked a little bit about counseling, so integrating that psychosocial and client-centered decision-making into all of our sessions. In order to achieve this, we need good communication. And then the last three, I think, are more kind of holistically other areas that we like to focus on in genetic counseling. So research, which is really, understanding what is evolving in the genetic space and the disease space so that we can provide the most up-to-date information to families. Making sure that we remain an integral part of the healthcare team and that we continue to have that professional identity and these values, which again gets back to that sense of cultural humility. So with that, I will end my brief section, and I am looking forward to taking questions later.
You're muted.
Nisha, you're talking on mute.
Thanks. Sorry about it. Thank you, Amy. Thank you so much for that summary of genetic counseling and all it entails, specifically within the US context. And we will be delving a little bit deeper into a few of these aspects in comparison with what happens in India during our discussion session later. Our next speaker from the Indian side is Dr. Dipanjana Datta. Ramya, if you could bring up Dipanjana's bio slide, please.
Yeah, sure.
Thank you. Yeah. Dipanjana is a board certified level 2 board certified genetic counselor based out of West Bengal in the northeast of India. And she also has a wealth of experience dealing with a number of diseases and a number of years doing genetic counseling in the Indian context. And she is a prolific speaker regarding the needs of patients as well as genetics, various aspects.
Sorry, taking a break because of the internet, I think.
Not an issue. Not an issue. Dipanjana has a PhD in molecular genetics and and she has a number of postdoc experiences as well as a lot of publications which highlight her expertise. She is also the state coordinator for the Organization for Rare Diseases India, and she will be speaking to us about her experiences in genetic counseling and her journey so far in the Indian context. I think we can have Dipanjana share her slides, Ramya.
Yeah, sure.
Sorry about that.
Thank you so much. Thank you so much for the generous introduction, and thank you, IndoUSrare, for having me here. What I would like to speak on today has been very well said by my previous speaker. And I will just go on saying a few things which show the Indian perspective of it. I will not repeat what she said about what genetic counselors do and what are we supposed to not do and what is exactly our competency, but I'll just bring in the flavor as in when we counsel on field in India, what are the issues that we face. So even before I start, and some statistics I would love to show and pull up over here, that in India there are a lot of deaths which are under 5. And when we say there lot of deaths under 5, these deaths are due to neonatal infections, diarrheas. They're reported as that, like cardiovascular diseases, kidney diseases. And in most of the cases, if we are looking at prevalence of birth defects, what the epidemiological studies say, there's 64.4 per 1,000 live births. Now, the ICMR has said that if we are talking about rare diseases, so India for a very long time did not actually have a rare disease definition. The reason being we didn't have a registry. We still don't have a registry. The registry is in making, but ICMR came up with cross-sectional studies, and from there, it was sort of hypothesized that 1 in 2,500 individuals would have rare disease. Now, India, which has a huge population, if we extrapolate that, understand that about 70 million people would be affected, and that's a huge burden. And 70% of them might be saved due to some management or some, interventions that can reduce the disability. In India, we know it's a land of beliefs and religion, and we believe more in the cosmic energies and our horoscopes rather than the scientific genetic data. Whereas the West, we can see that everyone is mapping the genome and they are coming up even before the child, when the child is there.
I think we lost Dipanjana there.
Yeah,
Yeah, she's just back.
yes.
So now NHS also thoughts coming up that the genetics should be screened. There are certain genes that should be screened at birth so that we can save all this. In India, unfortunately, still newborn screening is not a reality. Excuse me. Yeah. So we are still talking about introducing newborn screening, the very basic test. Why am I talking about this and why is this important? This is because there has been a number of publications which has stated that India is sort of the melting pot of genetic disorders. This being because that there are multiple endogamous group, which means that we marry inside the same community, and in some cases we marry inside the same families. Now this leads to accumulation of genetic traits that leads to a lot of these autosomal recessive diseases. Now, as we said, 1.3 billion people, 4,500 ethnic groups, 300 languages, 450 documented rare diseases in India. But what workforce do we have? So because I needed to say this, I needed to say all of that before. So we have only approximately about 192 junior genetic counselors, 77 senior genetic counselors, and approximately 150 clinical geneticists serving 70 million people. And that would mean 167,064 person per genetic expert. So as you can see that we are terrifically undermanned. So that's the first point, and hence in every space the awareness, the referrals are less, and hence also there is, with this also comes a lot of fear, also comes a lot of myth. Now, also globally, the cost of the tests have gone down, and in India also the cost have significantly gone down. Now, this has also impacted because, you know, these the genetic diagnostic companies are also hiring GCs, or they are also have genetic counselors in India who help in interpretation of the report, what my previous speaker was also talking about. But there is a conflict of interest because normally we wouldn't want a company genetic counselor to counsel a patient, but because we have so less numbers, this is something that is there. And though genetic counselors by profession, they have to be neutral and they have to be non-directive, but this is what the situation is in India at the moment. Now, also what we lack is, though a number of other places have the normal population, India does not have a base. We do have an Indian genome variation database, and very soon there will be an indigen database. But at the moment, the interpretation of these normal population or normal allele frequencies become very difficult. Hence, interpretation also is a bit different or difficult as far as India is concerned. Now, there was the rare disease policy, which was introduced a few years earlier, but then finalized in March 21, which actually said that we can have the entire set of rare diseases grouped under 3 heads. One, which could have interventions like surgical interventions or corrective surgeries. 2, which could have supplements which were approved and low cost. And 3, that had supplements or interventions but were high cost. Now, in such cases, they said that you can crowdfund, especially in case of the number 3 group. But the problem in India over here is, though we were trying to crowdfund, it had reached a saturation, and after a certain while, if money is not there, we are back to normal. Hence, when we counsel our families, we are not just counseling one thing. Though the patient comes to us with one issue, which is probably, a diagnosis of a child, which we are supposed to help them understand, or help them understand the right test, or help them understand the way forward, give them certain options and talk with them, but make their life less complicated. But in India, there are few unique features which we also need to counsel. We are counseling social issues like patriarchy, so X-linked disorders become extremely difficult to counsel, and we have to be very careful about what we are talking about, because in India, boy child is a precious child, and there are so many X-linked disorders with DMD, leading the list, or hemophilia leading the list. As we spoke about, just at diagnosis, we are unable to stop. We also have to understand how we can put them in a certain situation where they can have certain financial reliefs if they need. There are religious issues, so we cannot say all everything is not workable for every family. There we have to accommodate their religious beliefs, because it's ultimately the counseling is for them. There is social discrimination, which my previous speaker was also talking about, but the social discrimination becomes huge in India, primarily because the awareness is very low. And there's also a trend in India to destroy data when your child dies. So, when a couple comes in asking that, I have 3 deaths and now I want to plan a second pregnancy, you really don't have any medical data to look into. So these all become, so digging up the data, and there's no data storage. So digging up the data becomes very difficult. In India, it's just not about the couple. It's just not about the mother. There are multiple members in the family who are taking the decision. There's the mother's parents, there's the father's parents, there's the grandparents, there are also neighbors. There are, like in certain cases in the counseling sessions, we might have 5 people and we take the couple up in a second room, and we try to speak to them individually. We try to speak to the mother, try to speak to the father to get the exact information and get what the couple wants, and then give them the information they need. So there's a lot of digging that needs to be done. Also, there's lack of awareness and lack, even when if a genetic counselor is able to give them that the roadmap along with a clinical geneticist, it's very difficult for these patients to travel because some infrastructures are missing, and so it is upon us also to sort of guide them as to where they can go and get these infrastructures, which would be nearer, helpful, and financially viable. So in India, these are the unique features, just not the interpretation of the report. We just don't stop at that. There's a lot of other things that come into being. Also, we were talking about reproductive choices, and though there are technologically we have advanced a lot, but because of all these unique features, these reproductive choices also have to be carefully given to the family, respecting each of their mindsets and understanding what would not disrespect them as well. So although our job is to actually be non-judgmental and give everything possible, we also need to understand that we cannot hurt their sentiments or their feelings. But in every case, whatever our challenges or issues or barriers are, we need to involve the patient, and at certain times it might be suboptimal, but if that is what the patient or the family prioritizes, that is what has to be rendered. Now, there was a very nice slide with our previous speaker who said that we shouldn't become psychologists, but it is also our duty to prime them to go to a psychologist. The reason why I say this, because in India, mental health is an issue. And when we say that mental health is an issue, most of the family members, though they are very comfortable probably walking in a genetic clinic, they are not that comfortable walking in a psychological clinic. This child had a condition called ichthyosis, and she was having a body image issue. When I first spoke to her, she was very shy and she did not want, and her parents absolutely did not want to go to a psychologist. When we started talking about a number of inspirational characters, even Frida Kahlo, casually when I was telling the stories, she understood, the parents understood, and gradually, it was not in a day, but 2-3 days, they then started visiting the psychologist. So in India, we also have to take care of these psychological issues. And this is just one case. You have recurrent pregnancy loss, you have child birth traumas, and a lot of other things. Also, India is a land where genetic counseling was not introduced very long ago. Now, because it was not introduced very long ago, there is still a process that's going on, which probably UK, US already has been through. So the first process is there was a disinterest, and that doctors or patients did not want to come to a medical, a genetic counselor, because a genetic counselor, they didn't understand what the scope of genetic counseling was. Then gradually, in some cases, some GCs were able to pre-collaborate with neurologists, nephrologists, fetal medicine specialists, clinical geneticists, and a team was made. And hence these pre-collaboration precipitated and introduced genetic counseling to the Indian society. Now, we are still under this initial collaboration, and still an effective collaboration has not taken place. Hence, we still don't have a lot of guidelines or recommendation statements. It's still informing. It is still the major, we are following the West as far as the major guidelines are concerned. So once we have such an effective communication, that is the time when we probably will come up with the Indian guidelines, which is very much needed for our own social causes. Also, one thing I would like to highlight is that in India, the number of publications are quite low. So if you just search rare diseases, these are the number of publications. But if you look at India, it's only 12,835, which is again not because the burden is low, but because itself the choice that they will publish, they will go ahead, collaborate and publish data is quite low. And hence, in India, the number of clinical trials are also low. And if you just see one year, then we have barely published 1,000 cases, but then that is not the entire truth. So there's a lot of work going on as far as we are concerned, which is not being highlighted. The actual data is not being reflected, as a result of which probably India is not a viable place for the clinical trials to happen. And yet there are so many patients which are there, and probably the data keeping is also suffering. So a genetic counselor has to take into account all of these while counseling. And that is where I will rest my lecture and probably move on with the session.
Thank you. Thanks, Dipanjana. That was quite a comprehensive understanding that we have gotten about the scenario in India. I will now also bring Amy back onto the screen. So I hope everybody can see both our esteemed speakers. Thank you both for such insightful presentations. Just listening to you, we've learned so much. And I think the immediate thing that comes to mind is the stark differences in the scenario between India and the US in the space of genetic counseling. And I'd like to ask Amy, because she presented first, what are your thoughts after listening to what Dipanjana had to say?
Yeah, there were so many points that I was nodding my head at that makes so much sense. I think, one of the things that and part of it's just where I spend my time that I'm most fascinated with is you brought up the idea of newborn screening and genetic testing at birth. And I'd be curious to know from your point of view, what do you think is the biggest barrier for getting public health programs like that off the ground in India? Is it logistics, or is it that fear of social discrimination and some of those other pieces that I found that interesting?
So I would say the first thing is the cost. The cost is a huge barrier. And also we don't really have incidents. So see, even if we look at Europe, US or wherever, there is state-wise incidence of these disorders. So we know what to screen. For India, we really don't have that registry. We do have an understanding of what is prevalent and what is not prevalent, but that as an official document is still not there. Yeah. So to introduce such a program for the government, we really need to first have incidence and epidemiology report. Then only we can go ahead with such, as a public health issue. The second part is that the government outside, they actually support in some way. So now we have the rare disease policy, but still it is not fully in place. So even if we diagnose, what happens next? What will happen to these needs. So I feel logistically or as far as the state is concerned, we have to first understand that what we will do after diagnosis and how
Yeah.
we will take care of these kids. Then only we will spend so much money in diagnosing these diseases. So I feel unless we have this whole thing streamlined, it's very difficult. Though I would also like sort of say over here that a state like health being a state subject, certain states like Maharashtra, Karnataka, Goa, they have actually taken up newborn screening as a state chapter, but they are not screening the entire thing. They are screening just 3-4 things which we know are extremely prevalent, and that has started. So I think it's a start, and we, we will progress.
So, Amy, from your perspective, so she mentioned a lot of barriers and issues within the Indian context. When you come to the Indian diaspora, the Indian diaspora is one of the largest in the world. I think the largest in the world,
Yeah.
even within the US as well. What do you what have you seen, or what do you perceive as the most common barriers to accessing genetic counseling?
Well, and I think Dipanjana touched on a few of those in terms of awareness first and foremost. I think it's certainly hard to access something that you're not really aware of, or you have fears about, or don't really understand what the purpose is. So I would say awareness is a big thing. And I would agree in terms of the concerns around social discrimination in genetics. We have not had a great history of utilizing genetics in this country and the United States. And I think there is a very understandable fear around genetics and genetic information, particularly in non-white individuals. And so I would say, in my experience, those have probably been the two kind of biggest fears are just awareness, and then this fear of stigma and discrimination.
All right. Okay. So what I wanted to check was, we know that there are differences in the way different populations perceive the same situation. For example, the challenges that might exist in terms of infrastructure or availability is perceived and felt differently by different populations, and so the Indian diaspora. And you touched upon the cultural aspect of it as well. And what I also wanted to highlight, what we have seen at IndoUSrare during our work to support patients through our patient concierge, is that the Indian diaspora, the genetic diversity that exists in India is not fully understood elsewhere. And even though there's such a large population of people of Indian origin in the US. So do you have any comments to make on this? What are your thoughts on this? And maybe then I'll move on to Dipanjana to speak about the Indian context.
Yeah, I think that's such an important point, that a lot of what we currently know in genetics is very much based on Northern Europeans and white individuals. And so the utility of genetics is very different, I think, in different contexts. And I fully agree that we do not fully appreciate the wide-ranging ancestral groups present in India, and to better, to truly understand what we're seeing, and even when we find something, what does it mean? Does this mean that it is related to a disease? Does it not? Do we not know? And so this is a big issue, I think, in genomics, is the fact that we really don't know very much about non-Northern European individuals. And it's hard because we need to get more people to do genetic testing in order for us to get more data and to understand more. But that's almost like a catch-22 in appreciating that the genetic testing may not be as useful right away. And so it's kind of we're in a tough spot, I think, with that right now. But Dipanjana, I'd love to hear what your thoughts are on kind of our understanding of the of the Indian ethnicities.
Yeah, so we do face a lot of problems because 80% of the report comes back as a variant of uncertain significance. And we followed obviously the ACMG guidelines and currently the AAMP guidelines that has also come in. But at the same time, we do rely a lot on the patient studies, the modelings which are there, the scores that we can give. But the problem is that unless we really have an idea of the allele frequencies, it's very difficult to understand whether it's actually a polymorphism in the population or it's actually a disease-causing one. And this is especially true when we are coming for, genes which have very high minor allele frequencies. We do have certain genes like that, and that is where it becomes very confusing. Also, to a certain extent, in these cases, we do family studies, we try to do linkage studies, but unless we do a functional study, it becomes extremely difficult to, conclude that. I was in some international seminars like in October, and many places they were doing transcriptomics. Unfortunately, in India, though we had machines and it is being done in research mode, but it's not as fluid as it was while we were working in US, that you just clone and you do a transcriptomics and you understand the functionality of it. So in these cases, we have to, our counseling becomes very difficult. You understand, I'm counseling to a patient with 2 VOUSs where I see a huge genotype phenotype correlation. And but still I cannot go back and say that, this is the disease causing one. I can only say that we presume this is the disease causing one, and I really don't know what it is. So in spite of spending so much amount of money, we would be back at a space where we probably are in a black box. So right now, hence our pre-test counselings have to be very solid. So when we are counseling, we actually have to give them the yield. And I hope junior genetic counselors are listening. When we are counseling in an Indian scenario, even before jumping to what test should be done, we should first talk about what is the yield of the report. Like what are my differentials and what like which have been given to me, and what would be the yield. Because the couple might just say that if I understand the yield is so low, I might not, want to go for a test. I might not want to, I might want to adopt a child in that case if I want a second baby. So these kind of things become stigmatic. But obviously we are following ACMG and AMP guidelines and, doing whatever best can be done under the scenario.
Dipanjana, just to follow up on a couple of points that you've raised now and earlier. One is you mentioned regarding the technology. So that is obviously a challenge in India from what you have spoken. One question is for both of you is what are the collaborations that we can enable, which is our vision and mission at IndoUSrare, to make this process more effective? And secondly, is genetic counseling seen as an unnecessary cost? Is it something that people want to take up and are not able to afford to? Or is there a social hindrance because they think, oh, it's not something that we really need to do? Is that something that you see in India, Dipanjana?
It's a bit tricky to answer the question which you have asked. So technology wise, I think everything is in India. The problem is the interaction. So maybe people are doing everything in the scientific labs, which is not being percolated here. And also what we actually call as translational research is less, though there are a number of government grants, there are number of opportunities, but how many clinicians are actually applying for these grants, or how many genetic counselors by themselves are applying for these grants? None. Nothing of that sort is happening. So I believe such collaborations, if we can have with your help, and if there is a Indo-US actually collaborations, those can be pulled up where, a lot of these logistics can be I would say delineated. The second question which you asked, whether genetic counseling is considered as a burden. So understand there are, what I'll say will not be pretty, but there are three things that matter over here. Number one, does your clinician believe that you need genetic counseling? That's the first thing, because in India, it's a very clinician driven model. So the neurologist or the nephrologist actually emphasize that you need to go and see this person. These patients will ultimately go and see the person. So it's the main seed is there. Also, there are issues which comes through as where will they find these people? Because as I said, we are very rare. Even we are rare. Okay, where to go? Now, the clinician, though they understand that I need this person, might not have a person in their hand or might not know a person to whom they will refer. So, so the need is there, but probably the way they can approach is not there. So that is one part. The other part is that, we are not medical people. We are not medical people. So many people in India still believe that because we are not medical people, and this including doctors, that we shouldn't be in front of the patients at all. There's no need. Okay, that's why I spoke about that resistance which is there. All right. So this is still evolving. I understand that every country and every counselors in every country has gone through this. We are making that transition. And so there is, to a certain extent, there is a, pull and a push, both. So there are clinicians who absolutely, have been very supportive. And there are places where we have been not, probably in the team, and we are outside the team. So it definitely depends on the how and where you are working, and also the very fact that we are very less. Today, if we were very, if we had a significant number, and we could reach out to a significant people, then people would have understood the need and where things are changing. But the problem is that the number of people who are coming to us are very small. That amount is also very small. Hence, to comment on, whether we are making a difference or not, whether we are needed or not, is difficult. It's just few people's opinion here and there.
So Dipanjana mentioned that you have like one expert or one genetic counselor for around 150,000 patients in India. So Amy, is this anywhere close to the number that we see? So is the lack of trained genetic counselors an issue that you also see as well? And I think a few people had asked questions regarding that also.
Yeah, I would say, I mean, certainly, yes. I don't know that it is quite to the extent of what you're seeing in India, though. If we look at clinical geneticists in the United States, it's quite bad as well. I think there's maybe 2 per 1 million geneticists per individuals in the US. Genetic counselors are more prevalent, so it's not quite as bad, but understanding, and Dipanjana did a great job of showing the availability of genetic testing and the costs going down, understanding that that's happening, and we're going to want to see more individuals. There is more of a reason to have genetic testing. There's more availability of genetic testing. The availability of genetic counselors is not really matching up with that. So absolutely, I think that we also have kind of a workforce crisis in terms of genetics expertise. In the United States, we've been trying to look at that in a number of ways. One is providing telehealth or kind of electronic ways to get genetic counselors to individuals, but also training other healthcare providers to have a better idea about genetic testing. So yeah, I don't know that it's quite as low as India, but it's certainly, a problem here as well.
Definitely.
So I'll
that-
quote NSGC. I'll just quote NSGC over here. So they said that normally it should be one genetic counselor every 20,000 people. It's something like that. The stats is something like that, which is not there. So that is not there anywhere.
Yep.
Yes. So one of the aspects that we are trying to address at IndoUSrare is this, the inability or to access a genetic counselor in person and provide a platform where patients and families can safely, in a controlled and safe environment, be able to speak with a trained genetic counselor sitting anywhere. So we were very lucky to partner with a nonprofit foundation in India and be able to help this to provide an e-counseling service for people sitting in rural India, where they would not have had that opportunity otherwise. And we were able to see the benefits and the effect of the work that genetic counselors such as you all do. I want to take a step back from this really detailed discussion to just break it down into what the parents or the patients go through when they have to consider genetic counseling, and just take it a step at a time for people. I know a lot of people are very well aware, especially in our audience, but just to break it down, when should a parent consider genetic counseling? Is it only when a genetic test is prescribed, or does it hold true for any other prenatal diagnostic test? How does it work? When do you all come in, and how would they go through this process? Amy, do you want to start first, please?
Sure. So I would definitely say no, it should not just be when a genetic testing has been ordered. To Dipanjana's point, it's so important to meet before genetic testing is ordered, so that we can appropriately talk about the yield and the risks and the limitations and the benefits and what we may find, what we might not find, and what the next steps would be depending on what we see. So cannot stress enough that you should not wait till after genetic testing to see a genetic counselor. There are a lot of indications. If you have family members, if you look at your family history and you see family members with heart disease or with cancers, or, there are a number of reasons why it would be helpful to go see a genetic counselor outside of even getting any testing done, just looking at your own family and medical history. But certainly when you mentioned other prenatal tests after ultrasounds, if we see something, I'm hard pressed to think of situations where it's not a good idea to see a genetic counselor. But yeah, typically, at least in the US, would kind of depend on your insurance policy and how that works. But you could request to be referred to a genetic counselor based on a number of different indications. And then it does become a matter of, accessing a genetic counselor, which can be easy or difficult depending on kind of where you live geographically. I don't know if it's similar for you, Dipanjana.
No, so we as genetic counselors, we don't get too many walk-in patients. Most of them are referred patients. So when we say referred patients, what we get is, if there is, as you pointed out, Amy, very correctly, that if there is a family history of a sibling or a brother, or a previous child, or a neonatal death, or a stillborn, any such histories, right now we do get referrals. Or even if there is more than 2 or 3 pregnancy losses, depending on the age and everything. So we do get a referral for these cases. We also get referrals for cases with, fetal anomalies. If you can see congenital anomalies in the fetus, we do get referred for cases for adult onset disorders, like if I'm seeing Huntington, Parkinson's, Alzheimer's in the family, or even of hereditary cancer for that matter, like breast cancer, ovarian cancer, any Lynch syndrome, or those kind of cancers which are there in the family. So, but frankly, in India, we do get few surprises also. Like if we see a lot of consanguineous marriages, there are couples who come up and ask that whether they are at risks or not. We also, because thalassemia is extremely prevalent, we do get couples before marriage, they come up and ask whether, if at all there are risks, whether they should go ahead with it. It's tricky though, because it's also discrimination. But we do get couples who come up like this. So yeah, pretty much as she said that genetic counselors can be involved in many places depending on how the the couples or the family or whoever is thinking, and how the clinicians are thinking. Like even with infertility, we get pulled on to so many times with so many cases in decision makings also.
Yeah. How about parents who have children or patients themselves who have an undiagnosed condition? How would that factor in? Because we have a number of those as well. How does this change? How does this
Amy, you want to take that first, or?
Sure. I mean, in the US, I mean, we often have individuals with undiagnosed conditions. So, generally in those cases, I think they're often being referred to the geneticist or to specialized programs that focus on undiagnosed diseases, where they are doing more robust genetic testing, typically whole genome sequencing. And so, honestly, kind of similar in terms of asking for a referral to a geneticist or genetics clinic who specializes in trying to determine a rare disease or an undiagnosed disease. And in those cases, genetic counselors are often really part of that team as well. So that's typically how that would work. And there is the Undiagnosed Disease Network in the United States, which I cannot recommend enough, but genetic counselors are involved in that as well.
Yep.
See, again, if it's an undiagnosed disease, diagnosed disease network, which is a part of the greater network, which is worldwide. But at the same time, understand that sometimes probably it's not very feasible to do a whole genome sequencing for even the couples to approach in these networks. All right. So in those cases, genetic counselors can give them a number of options. And these can be discussed with the gynecologist or the clinical geneticist, and we can come up with something that works for the family. It can also be that they might want go for an adoption depending on their age and how they want it. But as I said, that we have to in these cases involve the patients and what they want, because I have had certain families who said that even if I have risk, I would like to have my own children, and I'll go ahead. And in those cases, we can be supportive and we can do whatever we can, prenatally and when the child is born postnatally, to ensure that at least early intervention is available to them, because ultimately it's their decision. And, if they understand the risk and want to try, we are no one to say that, don't try. So that is where I believe that, our perspectives is not that just we have to be there where there are interventions available. We can be supportive to their decisions and understand what they want and take it further. So obviously there are undiagnosed diseases, but doesn't mean that, there is still no way out.
Yeah, sure. Thank you. Thank you both so much. I think we are past the hour, but this has been so interesting, and we have a few questions. I have addressed a few of those questions. But I want to wind up here, and I'll relay the questions that people have asked, which I was not able to speak to you about offline. So thank you folks for your understanding. What I would like before we end this panel discussion is a take-home message or a final note that Amy and Dipanjana would like us to, leave the session with. If you had one point that you wanted to end with, what would that be? Amy?
Oh, that's hard. I think my one point would be, the importance of making genetic counseling or awareness around genetic counseling, making it that individuals more aware of genetic counseling, and recognizing how integral of a part we can be to the team, and not just in the medical sense or the very scientific sense, but how important it is when we're talking about these diseases to have someone who holistically looks at the patient and everything that they're coming to the table with. So yeah, I would just encourage awareness around genetic counseling and the importance of us.
I'll just make a comment over here rather than a statement. So even now, when I say that I'm a genetic counselor, many people first, they will nod their head and they will say, "Okay, what do you exactly do?" So I, I would love that, genetic counselors are given their due respects. The awareness around rare diseases is one, but awareness around of genetic counseling should be hand in hand with awareness of these genetic disorders, because it's as Amy has beautifully said, that we are looking at it holistically. Sometimes there might not be an intervention there, but the couple might be very relieved without. So that is also necessary. Though we are providing scientific information, we are doing that holistically, thinking about the needs of the family, and that is something which is a value addition. And I believe that that respect should be given to the community. Yes.
Definitely. Thank you, both of you, such wonderful points. And along the lines of this, both of you have spoken about having awareness about the importance and the work that you do, so that the community at large, both the patients as well as the referring doctors, are also aware of the wide possibilities. That's an initiative that we have been taking at IndoUSrare. And one of the aspects that we have done towards this end is to create a pamphlet, which both Amy and Dipanjana have been kind enough to review and provide feedback on. And I think we have a brief preview of that pamphlet, which will soon be released in multiple languages, English first, and 4 or 5 more Indian languages to disseminate among the wider public. Ramya, if you could just bring that up on screen for everyone to have a sneak peek into, and then we can just remove the spotlight, so Ramya will also be able to share her screen. Yeah, all right. Yeah, so this is our pamphlet. Thank you to everyone who has contributed, and thank you, Dipanjana and Amy. So again, this is a small initiative towards building awareness and about genetic counseling and what the endless possibilities are. And this is what we'd like, to take home from our side, that building awareness is one aspect, and building collaborations, such as this pamphlet, as we've had a cross-border international collaboration to be able to bring this information to you. So building collaborations for this purpose is also essential. So any patients who would like to contact a genetic counselor, please feel free to reach out to IndoUSrare and and learn from Dipanjana and Amy's insights here as well. And also, if anybody wishes to contribute and volunteer or be part of this initiative, you can also reach out to us and be part of our research core, which is a growing network of clinicians, physicians, and other experts, including genetic counselors. So please, we welcome all collaborations so that we can help rare disease patients in India, US, and globally. Once again, Ramya, could you stop screen sharing? I'd like to. Yeah. Once again, thank you, Dipanjana and Amy, for your time and your insights. And we have a number of messages coming in, thanking you for your insights. So I'd like to just relay that. Thanks a lot.